So thank you all participants for now at 100 participants and 5 minutes past 6. So I would like to call the meeting to order, and I would like to start by introducing myself. My name is Dr. Susan Nabulindo. I am the Secretary of the Kenya Society of Anesthesiologists, and I'll be the moderator for this meeting today. So before I introduce the speaker for today, let me just make a few remarks for housekeeping and reminders that we shall all remain muted during the presentation. We shall use the chat function of the meeting for any questions. So if you have a question during the presentation, kindly feel free to put the question down at the chat, and we shall get it and ask it during the chat, the question and answer session at the end. We will also like to, if you would like to speak, and we'll pick you from the audience and give you a chance to make your comment at the end of the talk. So without taking much time, I would like to also thank our sponsors for this particular CME, who will also have a chance to a few minutes to talk to us after the speaker. So today, our topic is multisystem inflammatory syndrome in children, something that we have all had come up during this pandemic. And we are privileged to have Dr. Bhupi Rheel, who is a consultant pediatric critical care specialist. Dr. Rheel is trained in various continents, has worked in various continents, and we are privileged to have him working with us currently. He started his medical training in the United States of America at Boston University School of Medicine. Then he underwent his pediatric residency, became a pediatrician at Miami Children's Hospital. He then spent time working at the University of California, San Francisco in the pediatric critical care unit, where he also underwent his pediatric critical care fellowship. He holds a certification from the American Board of Certification in both pediatrics and pediatric critical care. Dr. Rheel has also worked in London, in the UK, with the Children's Acute Transport Service, and also at the Great Ormond Children's Hospital, mainly in the pediatric critical care units. He gained some experience in anesthesia at the King's College Hospital and the Pediatric Trauma Royal London Hospital. So currently here, Dr. Rheel is a lecturer at the Department of Pediatrics and Child Health at the University of Nairobi, and also consults at the Pediatric Intensive Care Unit at the MP Shah Hospital. So we are privileged to have him talk to us about this new diagnosis that has come up during this time of the COVID pandemic. Welcome, Dr. Rheel. I think you can start. Mute yourself and put your video on and proceed. Thank you.
All right, thank you, Susan. That's quite the introduction. I guess my only regret in my career has been that I didn't become an anesthetist. But anyway, I'm very happy to do this talk for KSA. And the reason I chose multisystem inflammatory syndrome is that it's come up quite a bit over the last few months, like you were saying. And we had a case recently, and I would like to discuss the case. And actually, the reason to bring it up now would be just to inform people that to think about the diagnosis, because as far as once the diagnosis is made, that the the appropriate treatment is given, the result is quite remarkable, and as I'll show you in the case we had. So so earlier this month, on the 5th of September, just after midnight, we had a 11-year-old boy with no significant past medical history, who presented with a 5-day history of fever, sore throat, cough, red eyes, and truncal rash. He had been seen by his pediatrician 4 days prior to that and started on Augmentin and ibuprofen, but had no clinical improvement. On the day he presented to us, he had worsening dyspnea and also complained of intermittent chest pains. His vital signs in the accident and emergency department showed a heart rate of 90s. It's a bit tachycardic for an 11-year-old. Respiratory rate of 40s, also tachypnic. Adequate blood pressures for his age, so 105/61. And his oxygen saturations were fine at 96% in room air. His physical exam was remarkable for bilateral conjunctivitis, mucositis, a generalized rash, and some peripheral edema. Like I said, his blood pressure was fine. He was quite tachycardic, but overall, from a hemodynamic standpoint, he wasn't too bad. His capillary refill was about 2 to 3 seconds. And there was some report of epigastric tenderness on examination. So bloods were drawn. In addition to this, a blood culture and was taken. And you can see that his white cell count wasn't too elevated at 11,000. He had a bit of a neutrophilia, and actually what is remarkable is that he had a lymphopenia of 5%, and you can see that his CRP was significantly elevated at 254, and his urea and creatinine were elevated, creatinine up to 269, and urea up to 20. So he was already in a acute kidney injury. So he had the working diagnosis of sepsis and acute kidney injury, as would be suspected with that kind of presentation and those labs. And he was admitted to the isolation ward as a rule out COVID. So a nasal swab was sent for PCR, and he was put on the isolation ward. So he basically presented just after midnight on the 5th of September. And so by the time he got to the ward, it was probably about 2 a.m. He was started on some IV fluid rehydration and some antibiotics. So ceftazidime was started. And over the next 4 hours, so overnight, from about 2 a.m. to 6 a.m., his condition deteriorated significantly. He developed respiratory distress. He had some hemodynamic instability, tachycardia to 140s, cool peripheries, and weak thready pulses. And his blood pressure, which had initially been quite adequate, fell quite significantly with means in the 40s and 50s. Of significance, he remained anuric overnight, and that's why he was then transferred to the pediatric ICU when we got involved in his care. He came with the initial diagnosis of septic shock, so he probably came in about 6 a.m. in the morning. And he was just initially put on high flow nasal cannula at 40 liters per minute with an FiO2 of 60%. With that, he was saturating quite well. His respiratory distress was still there, but was a little better being placed on high flow. He received a fluid.
Hello, Dr. Rheel, we lost you. Sorry, kindly excuse us as we try to get back Dr. Rheel. Yeah, thank you, Dr. Rheel, for coming back, and sorry about that to everyone. Dr. Rheel got logged out.
Yeah, sorry about that. Can you hear me now?
Yes, we can hear you.
So the child was transferred to the pediatric ICU with the initial diagnosis of septic shock, and he was placed on a high flow nasal cannula with improved SATs and an improvement in his respiratory distress. So he received one fluid bolus of 20 mils per kilo and was put on maintenance fluid, and we started inotropes, adrenaline actually, peripherally, and then centrally once a femoral line was placed. At this point, we kind of, after he was adequately resuscitated. His blood pressure was a little better. We sat back and just thought about the history and spoke to the parents. And with the history of rash, fever, conjunctivitis, and AKI, we suspected the diagnosis of MIS-C. And went on to check further inflammatory markers and order an echo. So this was, I guess, during the morning hours of the 5th. So there we have our labs from our inflammatory markers that came back, which was early in the afternoon. So we had elevated D-dimers at 7.6, troponin was elevated 588, and a ferritin of 2711. So significantly elevated inflammatory markers, as well as a high D-dimer. He was quite acidic when he got to us. So the initial pH, this is a pH after we had started adrenaline and got the central line in. So his pH was 7.24. He was obviously tachypnic, blowing of CO2, but his lactate had already gone up to about 5, and bicarb was sitting at 13. So this kind of set us on the way. We asked for an echo, and see if I can play this for you. This is a 4-chamber view of his echo, and you can just see how his function was drastically affected, in that his ejection fraction that day was in the low 30s with that echo. So we debated whether to intubate him at that point. I felt that it would possibly help his left ventricular function, but on the other hand, he was quite alert, and he had somewhat settled with a bit of inotropic support, actually quite a lot. He was on adrenaline of 0.2 by this time. But we decided to keep him on high flow nasal cannula and start the treatment for MIS-C, hoping that he would turn around, with the thought that he would get intubated if he was to deteriorate anymore in terms of his cardiovascular status. So IVIG, as you can imagine, 2 grams per kilo for an 11-year-old who weighs 30 kilos is comes to over 500,000 shillings. And for a patient whose insurance cap is at 1 million, that's a significant amount. But speaking to the parents, we decided that it was necessary to give. So we ran IVIG at 2 grams per kilo. We also gave methylprednisolone at 2 milligrams per kilo per day, and started low dose aspirin at 5 milligrams per kilo per day. And I must say, I've never seen such dramatic improvement after IVIG. And he got the IVIG over night, on the 5th night, going over to the 6th morning. And by morning, we were already weaning adrenaline, and his perfusion was improved. He actually, over the next 24 hours, came off high flow nasal cannula, went on to nasal cannula O2. His AKI began to resolve. So all this happened within a 24-hour period. And someone with an ejection fraction of just in the 30s to improve so drastically in such a short period of time was quite remarkable. You can see that the repeat labs, now this is probably on the afternoon of the 6th, after the night of getting IVIG, and you can see his creatinine had improved to 116, urea was down to 15, he was still lymphopenic, platelets had almost, well, we initially felt that was slightly low, they were up to 160, and his blood gas was already improving with a lactate down from 5 to the 3 range. So quite a dramatic improvement very quickly. And after that, he had a very unremarkable PICU course. He was fairly stable over the next few days, and was discharged from PICU on the 9th. On the 9th, we repeated his inflammatory markers and his troponin. You can see that the D-dimers was staying fairly elevated, but his troponin came down to 197. His ferritin was 1089. He looked much better. His CRP, which was down from 96, initially 254, down from 96, and then 24. And the gas, we stopped doing gases prior, but his gas had normalized, and he looked very well. He was then transferred to the ward, where he remained hemodynamically stable, no respiratory distress, alert, active, ambulant with a normal urine output. And you wouldn't be able to tell that this was a child who had such a poor ejection fraction just a few days before that. He was kept for the reason to give him steroids for a 7-day period as per the recommendation. So I gave him IV steroids for a week, and then followed that with 2 weeks oral, including a taper. So a total of 3 weeks of steroids. And he was, and just like how we do for Kawasaki's disease, give a 6 weeks course of aspirin. And a repeat echo was planned for 16th of September. I would have rather had an echo before discharge, but because of our IVIG, we had finished their inpatient cover. So the idea was to bring him back as an outpatient and do the echo at that time. So he was supposed to return on the 16th. He did return. Unfortunately, the cardiologist wasn't available, but we did some bloods just to check on the markers. Again, we were trying to limit the tests we do, just given the they didn't have the funds. So the 2 I chose were troponin, which were coming down, and the D-dimer, which hadn't changed, was also on its way down. Of note, and I think I didn't mention this, is his COVID test did come back negative within the 24 hours when he was admitted. So like I said, his echo wasn't done on the 16th. However, the plan was to do the echo in the next few days with the cardiologist as an outpatient. Unfortunately, he returned on the 19th with complaints of palpitations. On examination, he was quite tachycardic in the hundreds, but had a normal blood pressure, good perfusion, was alert, he was walking around, but was just kept complaining about these palpitations. And when we put his oxygen saturation probe in the accident in emergency, it was definitely not rhythmic. It was losing its beat to beat every about 5-6 beats on the tracing. So we decided to do an ECG, and the ECG showed PVCs actually. So every 5-6 beats he was having PVCs all of a sudden, although he looked pretty well and was hemodynamically stable. At this point, I wasn't sure what to do or what to expect to do, but we admitted him into the HDU for closer monitoring. His electrolytes were within normal limits, and just taking some knowledge from post-op congenital hearts, we decided to give him magnesium, even though his magnesium was in the low normal range. And thankfully, that actually resolved his PVCs. We ended up giving him 2 boluses of 50 milligrams per kilo. Overnight, he remained quite hemodynamically stable, and his repeat ECG was a normal sinus rhythm. We did end up getting an echo the following day, and his cardiac function was actually very good, and the ejection fraction was 66%, and no coronary aneurysms or coronary enlargement that you sometimes see with Kawasaki's disease and MISC. So I'll talk about the discussion, and I'll just again mention that I'm no way an expert on this disease. I think I'll give you a good overview of the current literature out there, and I suspect we may see a few of these cases if we've already seen one so far. So just going back to COVID-19, I think everybody keeps talking about it, so I won't go in too much detail. But as we know now, most children are asymptomatic and exhibit mild symptoms that don't really require medical intervention. And this was proven by one of the studies in the New England Journal earlier this year, where 171 children who had confirmed COVID-19, only 3 cases were actually admitted to an intensive care unit, and 1 death was observed. I know with the patients we've had at Kenyatta, we've had several that are positive, and 2 deaths that actually weren't likely. COVID-19 wasn't usually the cause. I think the comorbidities were usually what we were seeing. And I think that's what's been seen all over the world. But in May 2020, investigators from the South Thames Retrieval Service, STRS, who work in conjunction with the Evelina Hospital, so 8 severely ill pediatric patients who had a hyperinflammatory shock with multi-organ involvement, similar to what we see in Kawasaki's disease, so and similar presentation to what our child presented with high fever, rash, conjunctivitis, a peripheral edema, and a significant amount of gastrointestinal symptoms. They named this syndrome Pediatric Inflammatory Multisystem Syndrome, temporarily associated with the SARS-CoV-2 virus. For a while, it was being called PIMS-TS. Since then, other countries have also reported similar patients presenting. So this is from Public Health in England, and if you see when they were first getting their surge in March, their first surge, you can see that about 3 to 4 weeks following that, there was also the kind of same increase in the number of pediatric patients presenting with MISC, that became interesting and was also shown in a paper from New York. But this led to them thinking that there was a relation between coronavirus and MISC. So the Royal College of Pediatrics came out with their guidance soon after that for PIMS-TS, and really reiterated what the Evelina team was seeing with persistent fever, inflammation, neutrophilia, elevated CRP, and lymphopenia, all things that we saw in our child as well, and evidence of single or multi-organ dysfunction, and really what meeting criteria for Kawasaki's disease. It was important to exclude other causes, so bacterial sepsis, staph, strep, shock syndromes, and in the cases that were reviewed, and we'll go over some of the literature, the SARS-CoV-2 PCR may be positive or negative, and antibodies may be positive or negative. So just to keep that in mind. So this paper then came out once the pandemic had hit the United States, and this paper is actually from New York State, which if you remember, was quite hard hit in March, April time. And again, if you see the numbers of actual all patients with pediatric patients with COVID-19, you can see that they surge up, and then there's a 3 to 4 week lag between that and developing of the MISC syndrome, albeit they're much less numbers. But the reason to talk about is that it does cause significantly more illness than COVID-19 in pediatrics. So a similar kind of curve that they saw in England with a 4 week lag. The patients that we were seeing, whether they saw a total of 99 patients, 95 were confirmed to have MISC, and you can see the range of patients. So in Kenya, a lot of you anesthetists will deal with older children, young adults, and they also were getting it, and we possibly will see patients who are in the older age group that will present with MISC. Albeit, having said that, the majority of the patients are still between the ages of 6 and 12 in this study. Again, this was once the pandemic reached the United States, and then this study was done looking at collecting patients from about 42 states, and a total of 186 patients were enrolled in this study, out of which 131, so about 70%, had lab confirmation of the SARS-CoV-2 virus. That was PCR positive in 73 out of the 131, and 58 had antibody positive, but were PCR negative. So, and then what our patient falls is probably into this category, that maybe had a link to somebody who had COVID-19. The mom had reported that she was unwell about 4 to 5 weeks prior to this, but she hadn't got tested at the time. But we suspect that that was probably what the reason he was exposed to the virus. Again, in that study across the states, you can see that the age groups were up to 20 years, albeit the median age was around 8.3 in that study. And of note, really, and what's concerning is that 70% of the patients actually had no other comorbidities and were healthy children. So that led to the American Academy of Pediatrics coming up with their guidance. And again, I'll let you just read that, but essentially it has the same features as the Royal College. It was named Multisystem Inflammatory Syndrome in children, and really the persistent fever being a key part of the diagnosis. And then to make sure that there's no other plausible diagnosis, and have some kind of link to COVID-19, and not necessarily a positive test or a positive antibody test. So this study just came out actually towards the end of August in the Lancet, and this actually is quite a nice overview of MISC, and it basically looked at all the reported cases around the world. And there are 662 cases by the end of August. The American, African, or Afro-Caribbean take a higher percentage of the number of patients. Again, I'll mention that comorbidities are not 52% of the children who got MISC were previously healthy. Of note, when you take all the patients that have been reported, obesity as a comorbidity, so out of the, so 52% were previously healthy. Out of the remaining 48%, half of those were obese. So just to keep that in mind, that I'm not sure what the theory is behind that, but there's speculation that maybe the virus accumulates within the adipose tissue, and that's what's resulting in this hyperinflammatory syndrome. So just to go over the signs and symptoms, persistent fever, like I said, and I'll show you the literature, 100% of the cases have a persistent fever. Kawasaki disease-like symptoms with conjunctivitis, red eyes, red swollen hands, feet rash, generalized rash, red cracked lips, swollen glands, and then in some children, coronary artery enlargement, and sometimes aneurysms, albeit less than what you see in Kawasaki's disease. So there should be some evidence of organ dysfunction, at least one organ. Cardiac dysfunction is usually present, and I'll show you the literature up to 80% of the time, with some hemodynamic compromise, some shortness of breath in case you do have heart failure. And some children come with significant amount of gastrointestinal symptoms with abdominal pain and diarrhea. And there were several cases of children getting laparotomies for appendicitis as they present with such significant abdominal pain. And then there was a small amount with the neurologic headache, meningitis as manifestations. So there, I'm not going to spend too much time on this page, but basically this is the one which is worldwide reported cases. Fever 100% of the time in all 662 patients. You can see abdominal symptoms lie high on the list. Our child had a bit of epigastric tenderness, but not really complaining of abdominal pain. Conjunctivitis is high with 51% of the cases, and then a rash is usually present. And you can see that the list of symptoms is quite significant. So getting the diagnosis can be a bit challenging. So here, this is the study with across the state with 186 patients. And this I just put up because just to show you that a significant amount, 70%, will have 4 or more systems involved in the disease process. Looking at what systems are involved, the same study shows it quite nicely. As I said, cardiovascular 80% of the time, which I think is why we should promote these children to be seen in a pediatric ICU or be looked after in a pediatric ICU. And you can vasopressor support in 48% of those ones involved in cardiovascular, which have cardiovascular involvement. In our child, we saw a bit of arrhythmia when he came back, and that's less likely, about 12% of the time. As you can see with non-cardiovascular symptoms, the GI symptoms are quite heavy, up in 90% range in this particular study. Our child had acute kidney injury, which was on the lesser side in this study. But when we look at the overall data around the world, AKI is quite prominent, and I'll show you that in a graph to come. And here picture C basically just shows the overlap between the organ system involvement between the various different organs. And like I said, 70% in this study had 4 or more systems involved in the disease process. Looking at just the cardiovascular findings in a little more detail, you can see that out of the 662 patients that were collected, which were reported around the world, majority of them had a echo, so close to 90%. And you can see that half of that was abnormal, and 25% had an ejection fraction of what we had between 30 and 55%. So it significantly can affect the heart. Of note, the coronary dilation and aneurysms are much less than what you would see in Kawasaki's disease. So just to keep in mind, 6 principal elements when you're looking for the diagnosis. And I know I'm spending a lot of time on the diagnosis, but I think if you get the diagnosis, the treatment is fairly straightforward. Pediatric age becomes a factor, persistence of fever, the laboratory markers of inflammation, the manifestations and signs and symptoms of organ dysfunction, and lacking any alternative diagnosis. And again, both the Royal College and the American Academy of Pediatrics emphasize that there doesn't have to be a proof of infection. Just an exposure, especially with community spread, is acceptable to make the diagnosis. So how I know I'm going on about this, but in terms of actually differentiating it, the things to think about, I'd just say what things are unlike Kawasaki's disease, that it predominantly affects adolescents and children older than 5 years. So when we see children with Kawasaki's disease, they're usually below the age of 5 years. So anybody coming above that should be thought as having MIS-C if he or she has the same symptoms. Of note, there's much more frequent cardiovascular involvement with MIS-C. About 60% of the patients presented with shock, and I'll show you that in the data collected from around the world, all reported cases. And I've only seen one child with Kawasaki's disease who's presented with cardiovascular collapse, and I think that goes well with the literature. Only about 5% of children actually have hemodynamic instability with Kawasaki's disease. And in addition, with MIS-C, like we said, the GI symptoms are quite heavy in part of the diagnosis. And both looking at Kawasaki's and MIS-C really suggests that there is a similar pathophysiology going on, and hence the similar treatment that we are giving. And what is that mechanism, and what is the thought mechanism behind this? MIS-C typically manifests 3 to 4 weeks after the SARS-CoV-2 virus, as we spoke. And this suggests that the illness is, rather than being direct viral injury, that it's due to the development of acquired immunity, and likely due to delayed antibody-mediated dysregulated host immune response that's causing this hyperinflammation and damaging organs. Lab findings, again, elevated CRP, ferritin, LDH will show you the inflammatory markers, like we said, lymphopenia, thrombocytopenia, neutrophilia, and then looking at your heart markers, BNP, pro-BNP, and then AKI, and D-dimers, fibrinogen, troponin, all which were elevated in our child. I won't belabor this too much, but this is the trial showing how many patients presented with inflammatory markers. So I think once you have made the diagnosis on physical exam or suspect the diagnosis, then really ordering inflammatory markers, CRP, ferritins, procalcitonin if you have it, And then looking at your fibrinogen and D-dimers as well, and troponin, looking at the heart markers, and BNP if possible. In our case, we kind of limited the number of tests, and that was primarily because of the affordability that was there. And I didn't feel that getting more and more inflammatory markers to prove the diagnosis was going to really benefit or change management. This is the study just going over the same thing around the states, showing the different age groups and the different kind of inflammatory markers and lab findings that you should be looking for to make the diagnosis. So I'll end up with management, but the recommendations, which I don't fully understand, are to continue wearing PPEs, even if there is a negative COVID test. So that's currently the recommendation. Talking to colleagues with pediatric infectious disease, I think if your COVID test is negative, you can debate that, but that is the current recommendation, to continue to wear full PPEs. I feel, and from the literature, that most children should be managed in intensive care units, especially because the deterioration can be so rapid. And our child, within a 4-hour period, had really deteriorated rapidly. You can obviously send COVID-19 testing, empiric antibiotics, pending blood cultures in case this is like a toxic shock syndrome, which we don't tend to really see in Kenya. I'm not sure why, but I've rarely seen toxic shock syndrome in Kenya. Having said that, we did expand this child's antibiotics to add clindamycin in case there was a staph or a strep infection that we needed to cover in addition to the ceftazidime. Of course, in ICU, we'll get continuous monitoring and echoes and ECGs, as we spoke about, and then look for multi-system involvement. In terms of treatment, exactly what we did, we followed the guidelines that were available. If you go online, actually, they're quite a different set of guidelines, and different hospitals are doing slightly different things. But majority of them recommend IVIG with 2 grams per kilo, one-time dose. I'll just put a slide towards the end of the presentation talking how we can address that. In obviously, you know, for us, this child was we were fortunate enough that the child could afford the $500,000 IVIG, but that can be a problem for people around the country. And steroid therapy, the range can be anywhere between 2 to 30 milligrams per kilo. 30 milligrams per kilo pulse steroids for 3 days. And we went on the 2 milligrams per kilo primarily because we were going to give the IVIG. But I suspect if IVIG was unavailable or unaffordable, I would have probably gone for the 30 milligrams per kilo pulse therapy with a taper of 3 weeks. So given the need for early intervention and need to initiate treatment for multiple possible etiologies, many patients have received antibiotic therapies, like we said. And then assessing for clotting risk. Kawasaki's disease has usually has risk for thrombosis, so we give low-dose aspirin, which is what is recommended for MISC. And some cases have been given enoxaparin if if fibrinogen levels and D-dimers are significantly elevated. In our child, we chose to go for low-dose aspirin. Looking at the clinical outcomes just in the trial across the states, I just want to emphasize that 80% of these children were admitted to the ICU, albeit a small percentage actually got ventilated. 10%, but majority were given IVIG and steroids. This is the study across the states, and again, IVIG 77% of the time, and steroids were given 49% of the time. I think it's less of an issue for them as IVIG is readily available, and they don't have to face the same issues that we face. And again, 80% of theirs were admitted into the ICU. To end up, these are the clinical outcomes of children across the for all reported cases, so the 662 patients. And you can see that death, fortunately, makes a very small percentage if the diagnosis is made and the right treatment is given. AKI, in our child, was 16% of the cases. And you can see that shock, vasoactive agents, and respiratory support was required in a fair amount of the children. So how do we apply that to our setting? I think we should think of the diagnosis, because I think it is coming. I believe if we think our peak of COVID-19 was in mid-August, we should be seeing these children this month or coming few weeks, if they are going to follow the same trend. And to keep in mind that older children are also susceptible to this. And like we said, steroids would probably be the best option if IVIG is unavailable or unaffordable. It's cheap, it's accessible. You have to worry about the broad immunosuppression, especially if a child's got TB or HIV. So to keep that in mind, and then maybe restricted to short-term courses and just to those children who are severely ill. Like I said, I feel fortunate that this child of ours could get IVIG and afford it, but I think for a majority of the patients, that's not going to be an option. Children need to be followed up with pediatric cardiology for the development of coronary aneurysms or coronary enlargement, and that should usually start 2 to 3 weeks after discharge. So to conclude, yeah, it's a new, unusual childhood illness. I'm no expert on it. I've had N of 1, so I'm happy to answer questions. But basically, we're looking at a 3 to 4 week manifestation after an actual COVID infection. Keep in mind that you don't need to have positive antibodies, and you don't have to have an active PCR infection to actually diagnose the disease. Overall, thankfully, children will survive if IVIG and steroids are given, but the progression to shock and cardiorespiratory failure is quite rapid. And I think the two things I'd end with is that more research needs to be done to really understand why certain kids are susceptible to developing it and others aren't. And I suspect that with COVID-19, why some people get really sick and others are asymptomatic will provide similar answers to that. And I think that the thing I worry is about potential long-term sequelae from the disease, and we don't know what that will and how that will affect children in the future. I'll just end with this slide. I think the Evelina team are the ones who first noticed this. They have a really good slide that basically covers everything I've talked about in terms of treatment, looking out for clinical features, the laboratory features, and the therapy. And I'm happy to share that with anybody. Those are my references. I think it's majority of them are just from the New England Journal and Lancet from quite recently, because that's all the published data so far. Thank you. I'm happy to answer questions.
Thank you very much, Dr. Rheel. That is a very informative presentation, and quite comprehensive, and a new thing for us as anesthetists. As you know, most of us are spending time in the OR, but again, this will affect children, and as you have mentioned, there are children who were diagnosed as having acute appendicitis and they ended up having laparotomy. So we are also just in the same group of healthcare workers who might actually meet these particular patients. So allow me to go to the Q&A session, and I would like to basically read out the questions that are So I would like to read and start by reading the questions from the chat. So I would like with a question from Stephen Chebi. Stephen Chebi is asking, hi how does this diagnosis compare to rheumatic fever?
I think rheumatic fever doesn't necessarily present with conjunctivitis. Yes, you can get the rash and arthritic symptoms, but in terms of inflammatory syndromes and cardiovascular involvement to cause hemodynamic compromise so quickly, I don't think you see that with rheumatic fever. I don't think I've ever really treated a patient with rheumatic fever in the ICU, and these children, as you can see, his echo showed really depressed ejection fraction of 30%, and not necessarily just regurgitation across the valves. His actual LV function was so poor, and that's what's being seen across the world with such cardiogenic compromise.
Okay. Next is several questions on IV immunoglobulin. Alfred Nyasende is asking what is the cost of IV immunoglobulin. And then there is another question, again, saying that IVIG is likely to be unaffordable for majority of our patients. Is there data about the prognosis when steroids are given alone versus steroids in combination with the immunoglobulin? And then another, again, question on the availability of IVIG in the referral hospitals at the county level. Do we have at KNH, Dr. Rheel? So the cost, and what if we don't have immunoglobulin? Are there studies showing prognosis in comparison of, with the steroids alone versus steroids with IG?
I think they're less available just because most of these studies have come from the developed world where IVIG is quite readily available. To answer the cost question for this child, I know it cost us 550,000 shillings for 2 grams per kilo, and the child weighed 30 kilos. So you can retrospectively work out the cost per kilo, which is quite a lot. So it's very unaffordable, to be honest. And I think from the data I looked at, steroids are quite effective. Again, you have to worry about the broad spectrum immunosuppression that you're giving. I don't think there are large prognostic studies on just using steroids, but I suspect they will work quite effectively. Like I said during the talk, I would, if you don't have IVIG, I would use pulse steroid therapy if you're really worried about the child in terms of cardiovascular compromise. I would definitely give a pulse dose of 30 milligrams per kilo per day for 3 days, and then do a taper after that. So that's without IVIG. And sorry, I didn't get the third part of the question.
The third part of the question was, is there IVIG at the county referral hospitals, or maybe at KNH where you work?
At KNH we do. Fortunately, it does take time to get. We often use it for our Guillain-Barré patients, so we usually are able to get it quite easily. At the county level, I'm not sure whether it's available, but I highly doubt it with that cost factor, unfortunately. But I think if you make the diagnosis and you're out there, I don't think you should wait for referrals to county centers, especially if the child is deteriorating rapidly. And I would give a pulse dose of steroids. And looking at the literature in terms of what's out there and the recovery period, I think it will benefit the patient. Obviously, I don't have the expertise to tell you that it will, because I've never really used it on a patient like this. So.
Okay, Dr. Rheel will give you a break a bit. There are still more questions, but I would like Dr. Kaiser to, she has raised her hand, maybe to give a comment. Dr. Kaiser, Chelmit, please give her unmute right so that she can make a comment.
Okay, thank you very much, Dr. Rheel, for that excellent presentation. My comment is just about IVIG and use in conditions like Guillain-Barré and your Kawasaki disease that, of course, prompt use of IVIG in these two conditions has been associated with shorter duration of illness and better outcomes. That was my comment I wanted to make about the IVIG.
So thank you, Kaiser. So moving to the next question, Dr. Rheel, Dr. Caxton Nganga is asking, what will inform the choice of antibiotic? Because these children are presenting with an inflammatory picture. So how do you decide which antibiotic to put the children on?
So I think, to be honest, if you knew it was this syndrome and you had IVIG available and you could confirm it in one way, I wouldn't even use antibiotics, to be honest. The reason to use antibiotics is to cover yourself for not making an accurate diagnosis, and because of the difficulty of making this accurate diagnosis. So thinking about toxic shock syndrome, staph strep, present in a similar way in that they have a rash, you can have significant cardiovascular compromise from septic shock. Would I use it? Definitely. The type of antibiotic I'd use is probably broad spectrum. For toxic shock, we usually add clindamycin to give us good coverage of the gram positives. And then a broad spectrum third generation cephalosporin is great. Our renal people where we saw this patient don't really like ceftriaxone on a renal failure patient. That's why we went on ceftazidime. But in general, I would say any third generation cephalosporin, and I would add Clinda to cover for a toxic shock-like syndrome.
Okay, and Sunil would like to know what is the inotrope of choice as you start. When you get these patients, what do you start with as the inotrope of choice?
Oh man, that's a difficult question. But in general, I know all the adult people are going to say noradrenaline because that is your go-to drug, and I suspect that will become our go-to drug as well. But the reason I started with adrenaline is primarily because I feel that's more, it'll help our cardiac output better. And if our cardiac function is so depressed, adrenaline is our choice. And to be honest, in septic shock, if we did have a child who presented, I usually do start on adrenaline. Those are the guidelines for pediatrics at the moment. So to answer your question, adrenaline, it would be the way to go, but I don't think people would fault you if you were to start noradrenaline either.
Okay, Phoebe is asking a question which is quite interesting and of concern also, because one of the manifestations you said is the skin rash. And she's asking, is Henoch-Schönlein purpura a close differential here, considering dark skin may be a problem in identifying the rash? So like for your patient, was the patient light-skinned? Do we have a problem with identifying the rash and maybe delaying diagnosis in our population, the majority of our population, where we have a dark skin, if the rash is going to be one of the things we are looking out for?
Yes, I think that's a reasonable comment. It does make it difficult, and I'll be honest, I didn't really notice the rash. It was the mom who told us that there was a rash on this patient. So, and she said it's almost getting a little bit better than it had been, but it wasn't something very obvious when you saw the child, and it was the mom who actually reinforced that the rash has been there for several days. So. Yeah, I think it will be difficult, but you have to take it with in terms of a constellation of symptoms, and all the symptoms that are there. So peripheral edema, hands and feet, that's quite common with Kawasaki's and MISC, GI symptoms, and then the conjunctivitis is very is somewhat unique to Kawasaki's in this. So I think those are the kind of things you want to look for.
So another question on steroids again, you gave us the dose range as 2 to 30 milligrams per kg. So let's say you don't have IVIG. How do you decide what dose to start with? Does it correlate with the severity of the disease? Or how do you decide I'll start at 2 or I'll start at 30 milligrams per kg of the steroid?
Yeah, I completely understand that. And I felt the same way when we were looking up the literature about what to treat. That's what the literature says, that's what people are using, between 2 and 30 milligrams, which is a wide range. But again, I think either use 2 or use 30, and I wouldn't go anywhere in between. This is just from my feeling, from reading the literature. I don't think there's any evidence either way, but at this point. So I would say if you have IVIG, I would put the child on 2 milligrams per kilo per day. If I don't have IVIG, I would go for pulse 30 milligrams per kilo per day for a 3-day pulse. After that, a weaning taper, and to complete a 3-week course. So that's, again, that's not based on evidence, but that's what I think I would do if I was in that situation with a child. If I didn't have IVIG, I would give the highest dose possible, that highest recommended dose possible for at least 3 days. And get them to a pediatric ICU.
Okay, David Maundu brings in another perspective of plasma exchange. How available and affordable is plasma exchange as an alternative treatment for these patients?
That's a really good thought, actually, and I think it would try to aim to get these inflammatory markers out that we're concerned. I just want to reinstate that I don't think that doing plasmapheresis on a child or an adolescent who has active COVID to actually do plasmapheresis or to remove these inflammatory markers, because we don't know if there's a large cytokine storm at that point. But for this case, which is 4 weeks down the line, and the mechanism of action is thought to be a hyperinflammatory response, then plasmapheresis does become an option. Around the world, it has not been used, so I don't think we need to get into that. As far as the cost goes, we do that for sickle cell children. And I know each plasmapheresis round goes between 200 and 300,000 shillings. So it's pretty expensive. And I wouldn't try it in this because nobody else in the world has done it. And IVIG seems to be doing the trick. And plasmapheresis is not without its complications. And obviously, very few centers here locally are doing that.
Okay, yeah, so we have participants sharing their experiences in the last few months meeting patients who they think presented in such a way. So we have Rafael Makambwe, who says, thanks for the presentation. Sound like one case I had, which came as appendicitis. The patient had high fevers and mesenteric lymphadenopathy. Then Titi Karonga says we had a 15-year-old with similar presentation in Harare. Thank you, Titi. He received steroid, acetyl salicylic acid, and IVIG. The patient, however, also had significant intra-abdominal lymphadenopathy, and lymph node biopsy showed caseation suggestive of tuberculosis. And she asked, from your literature, have you found any association between this syndrome and tuberculosis?
No, I haven't actually. I didn't see anything between TB and, but I think with our population, we may have something to add for this syndrome, because obviously in the developed world, TB, the amount of TB is obviously less than what we see. So yeah, I don't have an answer for that, but it is very interesting. Okay.
Good, and then we have again a question of, say, somebody asking a question probably out of this presentation, and maybe you can comment because this was a issue of NSAIDs and COVID. These were discussions that were had early in the pandemic about avoiding NSAIDs in patients with the SARS-CoV-2. Any comment you can make? She's asking how we'll manage pain when they say NSAIDs cannot be used, although I know this was discussed earlier and refuted. Any comments, Dr. Rheel?
Yeah, I agree. I think I think those were early reports, not really, based on much evidence. And since then, NSAIDs can be used and they don't cause any issues or make things worse, especially in children. So I would go ahead and use that for pain. No questions asked.
Okay, so I think we have had a chance to go through most of the questions posted on the chat. Thank you very much, Dr. Rheel, for the wonderful presentation, and thanks to the participants for the interaction. Dr. Rheel, even if you didn't become an anesthetist, he's a friend of anesthesia through the Pediatric Anesthesia Fellowship. He's involved with teaching and rotating with our pediatric anesthesia fellows in the critical care units in so we are grateful to have you to support anesthesia in that way. So without further ado, if you allow me, Dr. Rheel, you can stay with us, but we'd like to move to the next part of the presentation.
Sure, sure. Thanks, Susan. I appreciate it. Yeah.
Okay. So I would like to invite Spencer Ocheng. Mr. Spencer Ocheng is the representative for Pharmasell, who are our sponsors today for this particular CME. Spencer, if you are with us, we'll give you a chance to make your presentation. Pharmasell is the country company working with the working with the, sorry, just a minute. So Spencer is representing Pharmasell, which is the country representative for the local agents of Hamel. Hamel is a company that provides injectables for use in critical care settings, and we are going to give him a chance to talk to us about their products, one of their products today. And thank you again for partnering with us in this particular CME. Spencer, you are with us? I had seen.
You.
So thank you. You can share your screen if you have.
Yes.
And welcome.
All right. I'm just getting to share in a minute. Can you see my screen?
Not yet.
All right. Just.
As Spencer tries to share his screen, I'm seeing a lot of questions on how you can get this particular presentation. In a few days, the presentation will be posted on the KSA website. And also there's the KSA YouTube channel where you can go and actually have this, view this presentation from the start for those who have come in late. So within a few days, you should be able to get that on those particular platforms. Okay. Spencer, you're able to share your screen?
I'm having a small challenge. Just give me another few minutes, a second or so.
Okay.
Can you see the screen?
Yes, now we can see your screen.
Okay.
Welcome, go ahead.
Okay, I'll be very quick. I just wanted to speak about Hamelin Pharma. It's a company that's based in Germany. So Hamelin is a leading supplier of high quality injectable generic medicines based in Germany. We specialize in supplying injectable formulations that are used in critical care, including water for injection, sedatives, anesthetics, analgesics, and antidotes. And everything we do is driven by the understanding that we are all patients. And at one point, who knows, we will all land in a hospital. Of course, we don't want to be the recipient of these, but if that happens, then we want to have really good quality medicines when that happens. And so that's what Hamel does, to just make sure we have the best possible quality of medicines. Now, I work for Pharmasell Limited, and Hamel is represented in Kenya by Pharmasell. Pharmasell was incorporated in the year 2009. We are pharmaceutical importers and wholesalers, and we are based at Division Plaza in Nairobi. A bit of background about Hamelin. Hamelin, the company has beginnings in the town of Hamelin in Germany, where the company bought a pharmacy, Ras Apotheke, in Germany in the 1890s. It is the home of the Pied Piper of Hamelin. There was this mythical figure who would play his flute, and all the children in that town would follow him all over the town. And then that town got its name from there. Now, Hamelin, Ras Apotheke, which was a pharmacy around the 1890s, was owned by Friedrich Wilhelm, who actually discovered morphine. And then the original founders of Hamel, Dr. Wilhelm Keisten, acquired that pharmacy in 1890. They upgraded it from a pharmacy to a factory and started manufacturing and laid the foundation for what it is today. Through the 1980s, it is a family-owned business, and they then continued the specialization and internationalization of the company, and also bought Phoenix Pharmaceuticals in the UK. So they expanded from Germany to the UK, and moving on, it was kept in the family, and they diversified, expanded into manufacturing and marketing of injectable products after, expanding into injectable products. So they created a sterile portion of the factory, and then moved into sterile production. From around 2014, they started concentrating on marketing and sales, and then divested the manufacturing unit to a contract manufacturing company that manufactures for key multinationals till today, and started concentrating on marketing its own products from that factory. And now currently do so in around 40 countries around the world. So this is an external view of the sterile production plant in Langesfield in Hamel, Germany. It is a high quality plant because it has been contract manufactures for the key multinationals, not just for Hamel, but other key multinationals in Europe and across the world. So the standard is very high. This is just a quick picture of the sterile areas. Like we have said, we manufacture injectable products. And so there is a very high need to have quality products for this. And as I said, this is just for critical care. The factory just does products for critical care. So there's a really high need for high quality injectable products of various types, like we mentioned before. So, so we specialize in the fields of intensive care and anesthesiology, and our product portfolio includes a wide range of anesthetic, analgesic, and antidote products. So from Europe to the Middle East, Africa, North and Southern America, pharmacists and nurses rely on our products and experience in the field of injectable forms. Product safety is really the nuts and bolts. Like I said, we are all patients at the end of the day. And the main thing is product safety. And so one thing we've really focused is on product packaging. Now, as most of you are anesthetists, as a supplier of injectable medicines, we recognize that the importance of getting it right the first time. So there is no room for error when you get a product in the ICU or in theater. So it's very important to get it right. And so our labeling is constantly evolving using intelligent packing design to reduce the risk of medication errors. Now, our labeling was designed with input from customers, medicines authorities, patient safety agencies, and from other trade associations from different countries. And so using different colors, stripes, and symbols, we ensure that important details are always highlighted from the packs that you get, the medicines that you always use. So at the bottom of the screen, you can see different symbols. Those all represent different different products that we manufacture. And the whole idea is to minimize errors in theater. So this is, I'm just going to take you through a slide that shows how we name and how we look at our packaging just to minimize errors. So you will see that we have the corporate identity. We have symbols for each product. So this could be a trachurium, for example. The green in here symbolizes the strength and the color. So the design of the color bar indicates different concentrations. So it could be 30 milligrams in XML. And then the total strength in the volume is right there. And this represents the different dosage forms. So for anybody who understands this packaging, then the lower, if it's just one stripe, it's for the lower dosage, and the second stripe is for the upper dosage. Now, this is very important, right from the factory, going all the way to the dispensing area and right into the theaters. So, for example, when you look at a pack of ours, you will see this green or this blue, and I'll show you in the next slide, there's a pack there. So for example, this will show the total strength in volume right there. This shows the strength in bars. This shows our corporate identity. And so for example, one key product that we have that anesthetists use on a daily is a trachurium. And like I said, the pack size is just what I've just shown. We have a symbol here for trachurium. Our naming is with hyphen. It's hyphenated with our company name, and the number of ampules and the pack size and the strength. So it's very important that all these things be very clearly labeled, because many times you find accidents happening or errors happening in theater, or even in factories when they are making, and you want to make sure nothing is, you leave nothing to chance. And that's one thing we have done, and actually won prizes in Europe for this. Another key product that we produce is Rocuronium Hamel, and this is available in Kenya and various private and public hospitals. And again, you can see the thread around packaging. There's a symbol there. There's a strength clearly indicated, whether it is IV or whether it is a vial. There's a corporate name and the strength by this line. It may look simple, but it's actually a very, very important thing. Everything here has meaning, and it just goes to show you the lengths to which some companies go to make sure that, some errors are really avoided. The other product that we have is Tramadol Hamelin, and I'm just showing these just so that you can get a feel. For example, there's this nice symbol here, that's for Tramadol. And again, this is right from the factory. And so, when we come out and explain these, we minimize, and explain in the theater, we minimize errors so that there's no mix between different products that are in the market. So very quickly, the other thing is we have ready to use syringe labels. If you can see, this is fentanyl, and we have labels here which can be peeled off and put on ampules or on the syringe, just to minimize, and then you can put the patient's name to avoid confusion. So this enhances patient safety. It enhances delivery of the right drug in the right concentration and in the right presentation. So there's a reduced risk of medication errors and a reduced risk of contamination. All of these are very important in practice. And I know no one knows this better than you all. There's a reduced workload also for nursing staff and releasing time for patient care. So the products available in Kenya are atracurium injection. So that's atracurium Hamel, which is 2.5 ml and 5 ml ampules. Rocuronium injection, the 5 ml ampules, and the Trabanol injection, 50 milligrams per ml, the 2 ml ampules. We are present in a lot of Europe, Middle East countries. In Africa, we're in South Africa and Kenya, and in the northern part of Africa. And in Europe, where Hamel began, it's very strong. And so what we just wanted to assure you is when you see this brand name of Hamel, what you see is quality that you can actually rely on. And our focus is basically on critical care and various brands. So thank you for the time and for listening to us. And we look forward to continuing partnering with the anesthesiologists and making your practice as safe as it can possibly be. Thank you very much.
Yeah, thank you very much, Spencer, for introducing us to your products. And I can see Raphael from Zambia is asking if your products or you guys are available or found in Zambia.
We are not yet found in Zambia, but there's a plan to expand from South Africa into other parts like Zambia.
Okay. So I can see there are no other questions on the chat and nobody is raising their hand. So at this point, I would like to thank all of you, all the participants for making this happen. Today we had almost 300 participants from all over Africa, and we are proud and happy to host these CMEs and share information. Rak Alum from Uganda is asking if you are found in Uganda.
What we're doing is we're in Kenya at the moment, and we are soon to branch out into Uganda. We'll soon start the registration process of products, into Uganda. So we hope to be able to do similar things in Uganda. We've been in Kenya for at least the last 7 years, actually about 8 years with this product. So it's time to move out into other East Africa. So just to answer him, yes, we shall be going into Uganda.
So again, thank you very much. So to all the participants from all over Africa, we thank you for gracing us with this, gracing this occasion. It's always good to host you, and we still welcome you to our upcoming CMEs. On behalf of KSA again, we would like to thank Pharmasell for accepting to partner with us to sponsor this particular CME. And lastly, Dr. Rheel, our specialist, who has given us an overview in detail of what we might experience in our practice going forward with the pandemic. So thank you very much. And at this point, I would like to call off the meeting, and I wish you a good evening. Thank you very much.